Good morning. I would like to thank you for giving us the opportunity to present the results of the CCURE multicenter clinical trial. CCURE is the first trial using bone marrow-derived cardiopoietic stem cells for treatment of ischemic cardiomyopathy. The rationale of this trial is that therapeutic regeneration is an emerging option in heart failure. Certainly, significant clinical milestones have been achieved with delivery of heterogeneous naive stem cell populations, yet variable trial outcomes hamper broader adoption into practice. And further evolution of stem cell technology is mandated to optimally target organ repair. Well, the concept that we used in the CCURE trial is lineage specification paradigm. In other words, how do we teach a stem cell to become a cardiac progenitor before being injected to a patient? Lineage specification mimics natural cardiogenic clues. The tested hypothesis was evaluated first in preclinical models and brought to clinical grade manufacturing, allowing scale-up to achieve target dose. So the objective of the CCURE phase 2 clinical trial is to test the feasibility and safety of lineage-specified cardiopoietic mesenchymal stem cells in patients with chronic ischemic cardiomyopathy. The trial is a phase 2, multicentric, prospective, open-label study with blinded core lab analysis. The patients were randomized in two groups. Patients in both groups were treated with an optimal standard of care medical therapy, while the stem cell treated group received an intramyocardial injection of stem cells on top of that. The target dose was between 600 million and 1 billion point 2 cells. Target population was patients with ischemic cardiomyopathy with 5 major inclusion criteria as listed here. The patients had a New York Heart Association class 2 to 3. The left ventricular ejection fraction had to be between 15 and 40%. All patients had to suffer from systolic dysfunction with a history of myocardial infarction, and they had to be in a stable clinical state and therapy for at least 2 months before their inclusion. For safety reasons, all patients had to be protected by an ICD, and if needed, the device was implanted at the time of the bone marrow harvest. So the specific goals and predefined analytical plan was to address, as in any phase 2 study, the feasibility. Are we able to derive the cells in a sufficient proportion of patients? Are we capable of producing enough cells and to deliver these cells to the patients? In terms of safety, we are looking for the occurrence of arrhythmias to make sure that the cell injection has no potential arrhythmogenicity nor other clinical side effects. And finally, in terms of efficacy, even if the trial was not powered to look at that, we wanted to follow the cardiac structure and function as well as clinical performance at 6 months. In terms of feasibility, all steps were fully successful, with the exception of steps that involved cellular expansion. This limitation was certainly determined essentially by the quality of the starting material. So as shown here, at baseline, both cell-treated and control group were well matched, with no significant differences in demographic data, risk factors, cardiac history, as well as medical treatment. Using a very precise electromechanical mapping device, the NOGA-guided system allowed targeted delivery of stem cells to the hibernating myocardium. So the median clinical safety follow-up was almost 1 year, with a minimum of 9 months in some patients. During this period, the number of arrhythmic events was equivalent across groups. Most of the arrhythmias were atrial fibrillation. We have 5 episodes of ventricular fibrillation were recorded in control versus 0 in treated group. In terms of adverse events, DSMB proclaimed the study safe as no significant relationship to CCURE therapy was noted with regard to adverse events. Finally, the results. This and the following slides will show you some efficacy signals. As you can see here, at baseline, both end diastolic and end systolic volume were similar between both groups. At 6 months follow-up, we observed a reduction of end diastolic volume in the treatment group and a more pronounced reduction of end systolic volume in the treated patients compared to control. What is even more important is that the reduction of the end systolic volume is greater than the reduction of end diastolic volume, indicating probably that the addition of myocardial tissue was actually contractile and not just thickness. At 6 month follow-up also, left ventricular ejection fraction significantly improved only in the CCURE group, indicating benefit above standard of care. Note that this improvement was almost 5 times greater with compared to without cell therapy. This translated into improved clinical performance in CCURE group determined by the 6-minute walk test. In fact, patients in CCURE walked 70 meters more than the control group. This was again statistically significant. In conclusion, CCURE is a first-in-class lineage-specified stem cell product developed for treatment of heart failure. The CCURE trial demonstrates feasibility and safety of cardiopoietic mesenchymal stem cells in patients with ischemic cardiomyopathy. And complementing standard of care, CCURE therapy improved cardiac function and clinical performance, and this favorable profile supports follow-up pivotal studies. In closing, let me to acknowledge the CCURE program as an international team where the discovery was made in Mayo Clinic in Rochester. Product center is located in Mont-Saint-Guibert, Belgium. A number of clinical trial sites, mostly in Belgium, as well as in Serbia. Also some clinical centers in the United Kingdom and Switzerland will participate to the next study phase. Thank you for your attention.
Thank you very much for this very interesting and stimulating study. May I ask first with 2 questions. When you look to this approach, I think there are 2 important points. One is the preparation of the cells which are injected, and the second is the technique applying or injecting the cells. I think they're all not very specialized in the stem cell preparation, but could you elaborate a little bit more about how you use the Nouveau and how you did the stem cell infusion?
Yes. So the Nouveau system is an electromechanical mapping system we use usually in electrophysiology. So what we use is to do 2 different mapping, one mechanical and the other one electrophysiological, and decide that we have 2 breakpoints to decide what is really dead, what muscle is really dead inside the scar, and what can be viable. So between 5 millivolts and 12 millivolts, you can say, okay, this is in the periphery of the scale, we have hibernating myocardium, and we use the Nouveau first for the mapping, and then for saying, okay, this is the place that you can put the needle and injecting it inside the myocardium. So we have done nearly 10 to 20 injections around the scale in each patient, depending on the size of the scale.
So from the left ventricle into the myocardium?
Yes.
With a special catheter, with a butterfly whatsoever to prevent penetration?
The catheter is done from Johnson & Johnson with a distal needle, and you can decide in terms of deepness what deep you will decide it, and you can decide it before the injection. So you decide it maybe 5 millimeters if you have within the middle of the wall.
Yes, please.
nice presentation. I mean, your results are smashing if they are reproducible. But you didn't tell us how you actually, maybe that's a secret, how you actually programmed your cells to the myocardial lineage.
It's certainly a secret in part. Well, what is very important is two phases. First, to decide we have to reproduce an embryological state that mimics the cardiopoietic formation with different part of products we put inside this black box, and we reproduce a very specified, more than 98% specified lineage mesenchymal stem cells without any skeletal lineage, without any adipocytes and so and so. That's the first part, and the second part is to scale up these very specific cardiopoietic progenitor cells to a number of 6 million to 1.2 billion in a very secure states, and these are two different phases of preparation of the cells.
So you use a soup of cytokines to do this? Yeah.
Kind of.
Like PET or anything that shows that you have some evidence that the reduction of ischemia by nuclear study, or any evidence that you have any engraftment there. And the second question, on your sham, did you also use the NOGA and you inject something, or you just, so how can you tell that this is not by stimulation, just by using the catheter with multiple injections, even of...
First question, the answer is no.
You don't have any evidence?
For now, I don't think so. So we have just 6-month follow-up, and we don't have enough patient to answer positively to that. Maybe yes, maybe not. The second, of course, not. It's not ethical to put cells inside a myocardium for 2 or 3 hours in patients, doing anesthesia. So no, these patients are, of course, knows really if they are in a treated group or not. But you can say, okay, there is a cue when you do a 6-minute walk test, and patients are clinically better, of course, because they say, okay, I have my cells now and I'm better. But the man in Rochester who look at the echo, he doesn't know if the patient has or not the cells. So this will normally not interfere in our results for the echo, assessed left ventricular ejection fraction.
So that means in echocardiography you cannot identify the point where the injection had been done?
No, actually, when we do our echo, some of my fellows who did some echo said, maybe I have something here, maybe it's cells or not. But I think that we know we have injected there, so we are reaching for that. And in echo, if you don't use Simpson or other global method you can have some subjective point of view, which is not the point of view of a core lab.
Yeah, but the stimulation of the NOGA needle can create, by injection, if you do multiple injection, can create maybe some stimulation of collaterals or whatever that potentially has nothing to do with the cells. So I think you have to prove that there is some physiological engraftment by nuclear or by PET, some metabolic, to show that you did something with the cells, that it's not like just a mechanical stimulation.
We have done that in the mice. So there is clearly evidence that we can find in the animal clearly these cells implanted with a very nice functional. So this is we know it, but for having it in human, we have to have some hard anatomically some hard to analyze. So it's not very ethical.
I think it's stimulating, and all studies today were very stimulating as yours. Thank you very much. I think we can to conclude.